John Wood. I'm the chair of the Florida House Health Innovation Subcommittee, and I'm so pleased to be here today and moderate this panel. Before I introduce the panel members, I want to make just a few opening remarks about our topic today. And obviously, it's important that we look at this issue of transparency in our healthcare system if we are going to have change in how our healthcare system operates in this state. The current third-party payment system used in health insurance and programs such as Medicaid effectively hides the true cost of medical services from the recipient. I'm going to quote from an article that was recently published in the Wall Street Journal, where a similar type of summit was held at the national level with the CEO councils. And in fact, I'm going to quote from the chairman and president of Aetna, the CEO, Mark Bertolini, where he talks about that the system that we're in, where we get paid by units of service, needs to shift to a population management system, which, and he goes on to say, you would be given a budget where you have to take care of all these people. It is yours. You manage it effectively. Then the system should organize itself appropriately and look for opportunities to make it better. 75% of the next $10 trillion in the nation's debt is Medicare and Medicaid. If we can stem the increase, we can work on the deficit. The second notion is transparency, which we're going to discuss today. We need to have a true market where people understand what the prices are for health care today. That's concealed. Imagine a supermarket where you go in with your cart and pull items off the shelf with no prices on them. You take it up to the counter. It's scanned. The clerk swipes your card and says, in 30 days, you'll get your credit card bill, and you'll know how much your groceries cost. Would you shop there? But that's how the healthcare system works. We need to create transparency in the system so people can understand how much healthcare costs. And even if the insured wants to get the best price, due to either having a high deductible plan or just wanting to pay less for their services or paying cash, most often those prices are not posted or easy to find. When the true cost of these medical services is hidden from the recipient, there is no reason for the consumer to shop around for the best value. When consumers don't shop around, prices continue to rise, and there is no incentive to increase quality. Although much of the healthcare system lacks transparency, there are examples where transparency and competition have worked. Areas like cosmetic surgery, laser eye surgery, concierge medical practices, medical tourism, and retail clinics. These industries are thriving by providing high-quality services and competing for price. The Florida legislature has taken steps to promote healthcare transparency. The Agency for Healthcare Administration collects healthcare data and statistics for the purpose of developing public policy and promoting the transparency of consumer health care information. The agency website, floridahealthfinder.gov, helps consumers compare providers based on quality and price. I've gone to this website. I think it needs improvement. And we're going to focus on that in the legislature, on trying to get better information to our citizens. Another state website, myfloridarx.com, publishes prices for the top 150 drugs by pharmacy so consumers can shop for the best cash price. In 2011, the legislature passed House Bill 935, which was sponsored by Chair Corcoran, which rewards and encourages primary care providers to post their prices and requires urgent care clinics to post prices. Unfortunately, we gave some incentives to the primary care physicians, but I checked yesterday, and so far only 6 physicians in the entire state have taken advantage of this option. So either the incentives are not overwhelming, or perhaps physicians just don't want to be bothered. The legislature has created a high deductible insurance plan option for state employees. We are going to be looking at our employee insurance plan this session, trying to figure out what's the best model to provide health care to our state employees. I'm sure there are many more great ideas to encourage and promote transparency in health care, and that's why I'm looking forward to this panel that we've had to discuss this. So we're going to start off with each of the panel members giving their opening remarks about this issue. And so let us start with Mark LaBorde. Mark is the president of Aetna of Florida, and he's responsible for coordinating services among product development, underwriting, finance, and actuarial to serve Florida's businesses. Mark, it's your mic.
Thank you, Chairman Wood. It's always good to have your CEO quoted before you get introduced, because all I can do is screw it up from here. So, as the chairman mentioned, our company has worked diligently around trying to bring cost transparency to the market. And that's no small challenge. When we think about the history of our industry, we have done quite a bit to, so to speak, shield the patient from the cost through the years. Things like $5 copays for wellness, for physician office visits, and things to that degree really mask the price of health care to patients, and as we call them from the payer perspective, members that are out there. And so we have a challenge in front of us, but we've done quite a bit to invest to try to address that, because we recognize that there is going to be an increased level of responsibility, and we heard it in the keynote address as well earlier today around when the keynote speaker spoke to the fact that you'll have a greater level of accountability at the patient level moving forward, accountability in their own healthcare decision making. So we find ourselves with the opportunity and the need for change to really enable that with what I think was also used as the term he used was meaningful, and we would say actionable information as well. This is the challenge that we have and the change that we must address. I know that we also have the challenge, and I believe Dr. Kiss from Florida Blue will speak to it, and I know we'll have other Aetna folks tomorrow talking around our efforts around reform, moving from the fee-for-service to more of a, if you will, policy measures that bring reimbursement for outcome and quality as rather to volume. But as we still see that much of what is being delivered is in a fee-for-service basis, how can we get that cost information out there to the consumers? I'll highlight one thing real quickly that we've done. At Aetna, we have something we call the Member Payment Estimator, and it's a program that through the internet, through computer, that our members are able to go out to, and for 550 healthcare services, they're able to look up by their zip code for those services their particular cost that they will incur in advance of that cost incurral for those particular services. What makes this powerful, and what we must have as part of all future efforts to the same degree, is that it takes into account where they are in their benefit. So to speak, the most simple thing would be to say how far they're into their deductible. It takes into account the physician, the hospital that they're actually going to. You can't provide averages. That doesn't mean anything. You have to provide the information that says, if you go here, it's going to cost this. And then you have to provide a range and show that within a given geography, I can tell you an echocardiogram in Jacksonville, my home, the range that I looked up just a few weeks ago for some personal needs was between $900 and $1,800 within our particular plan. And that is a significant range, and that's somewhat emblematic of what is out there. In order to control costs, we have to put those consumers into provide them the information and give them the ability to do that. One other thing, we had some discussion in the earlier panel, particularly Senator Negron was talking about some of the mobile applications and other things. We are investing in those, and we have purchased and has on the market iTriage. which I bring up because it's a service that is applicable to what we were talking about earlier, developed by 2 emergency room physicians. And it is a mobile app. Again, it's not limited. It is not Aetna proprietary, so if you want to go out, please don't do it now, but if you want to go out on your smartphone and download it, it is a mobile application that allows people to, so to speak, go through a symptom to provider pathway, that they can enter in what condition they're going through. Obviously, it's for non-emergent care, but for those services, they can enter in the information, what is wrong with me, what do I need to do, where do I need to go for treatment, and it will guide them to that. It clearly brings some of the GPS capabilities we talked about earlier into play and will help guide them through that process. That is the level of engagement that we have to facilitate and we have to make sure happens as we move forward through our reform efforts, through our efforts to control costs. That accountability and engagement is critical as we move forward. You know, there are challenges with this, and I wouldn't give full comments if I didn't say that simply providing the tools to patients and members doesn't necessarily mean that they're going to use them. First off, there has to be an incentive. We've talked about high deductible health plans. I agree with the earlier statement that was made. They are not a panacea. They do not fix all matters or substantially change the situation, but they do put the patient, when they're out there, in the position of having a financial responsibility, which is a point of engagement. Clearly as well, this is highly dependent upon the patient, the member, having the ability to have computer access. That's not universal. It's getting more prolific, but it's still a challenge as we move forward. And then it can't just be cost data. This is always the part of the debate. It also has to include clinical and quality data. And that's one of the great challenges we face. We do provide that data as part of our system. Members can go in and for a number of services and they can say, I want to test out for this procedure which hospital, to use an example, had the lowest mortality rate, who had the fewest readmissions. What was their frequency of actually providing this particular service that I'll be undertaking? And then it will stratify and give the results back to them. That is new. That is really innovative at this point, and frankly has to continue to develop as we move forward. You know, the other comment that I'll make is that we have a significant opportunity as an industry, speaking from the health carrier perspective, to reduce the complexity. When we think about the fact that I try to look at this from the provider point of view, and you think about it from a hospital or physician point of view, and you think that you have one fee schedule, Florida Blue, another with Aetna, potentially, probably another one with Cigna, Humana, you name the carriers you might have. We have to stop trying to distinguish ourselves in that capacity and move to more consistency of how we pay and the underlying policies so that this can be an effective and a potentially strong way to bring this information out to the market. Without that consistency, and I'll call it standardization, we'll continue to stress the system. So that has to happen as well. We're working towards it. We strongly believe we no longer should try to distinguish ourselves based on those administrative restrictions or policies therein. And so that's a big change. The last comment that I'll make is that this all works. It all works when there's competition. We face the continued challenge out there in Florida and the country that we have a number of instances where there are limited providers, whether it be hospital-based providers such as anesthesiologists or emergency room physicians, where really consumerism and patient engagement is irrelevant, because the cost will be the cost. And many of those particular specialties areas drive much of the cost. Also, we've seen a substantial increase in provider consolidation. From 2009 to 2010 nationally, we saw a 33% jump in hospital acquisitions and provider consolidations. That also limits competition. That also drives up costs. That will be a continued challenge for us within the state of Florida. So I've tried to highlight both some of the opportunities and some of the challenges, but clearly we're coming from a position as an industry, as I think Chairman Wood said originally in his comments, has done very little to bring this information out to the end user, so to speak. So we have a great opportunity, and I think we will, as an industry, do much better in bringing that out going forward.
Thank you, Mark. We'll hear now from Dr. Kiss with Florida Blue.
Hi. I just want to just kind of add on to a couple of things you said. And one of the things is when we look at both price or cost transparency and quality transparency, this stuff is complex. It is unbelievably complex in terms of what Mark was just speaking of, say the echocardiogram example. Let's take the example that in Jacksonville, an echocardiogram could cost between $900 and $1,800. But what that doesn't tell the patient who's looking at it is if they needed it in the first place. It doesn't look into the pattern of care in the system. Was that an appropriate test? It's a simple pricing. It's a simple matter of pricing. And it doesn't really involve some of the things about total cost of care. So the industry has then looked at these things called episodes of care and trying to come up with indices around these where you bundle together a series of services, attribute them to a physician, and try to come up with what is the total cost of care. Maybe it's heart failure, a heart failure episode. Now, there's several different systems out there that do this, and they're all imperfect. There's an ETG, episode treatment grouper, which is in Genix, which there's a study from RAND that showed it was as likely to correctly classify cost as incorrectly classify cost. There's another system from Thomson Reuters that's different methodology. Often you look at the same physician, the same codes, and come up with different answers. Another one, which we use all of them, frankly. Another one is the Prometheus system. The Prometheus system, when CMS went out and decided how are we going to look for Medicare on our cost analysis, they chose to go down the trail of the Prometheus system because they thought that was the most promising. But Prometheus has only developed that for 22 different conditions right now. So this is really complicated. And you're putting patients out there making decisions on price and some of the decisions on quality, often when they're really sick. You know, you're ask a young woman who just got diagnosed with breast cancer, is she going to want to shop? No, she's going to want to try to identify a system that'll take care of her in the best possible way and not have to go into a tool, not have to necessarily go into an online tool which will show her which hospital in the area might provide the services more or less expensively. Now, I think we may have a remedy to this, and one of the things that's really happening, and we're talking about it, is payment in medicine and the way things are being paid is changing, and it's changing fast. My job at Blue Cross, for Florida Blue now, is I run our alternative payment systems, and we're developing different ways to pay physicians that isn't fee-for-service, so you don't have to look at all of this. Right now, for Florida Blue, as of the end of last year, 25% of all the services, of all the medical care, was paid under alternative payment contracts, which were not pure fee-for-service. They may have had a fee-for-service component with a series of bonuses based on quality, that series of bonuses based on cost. So we have a huge patient-centered medical home program. I'll tell you a little bit about that, which is an accountable care program holding primary care physicians responsible for the care, both the quality and the total cost of care for their entire panel of Florida Blue patients. We've developed accountable care organizations. We have 6 of them that we've developed around the state now. Just about every hospital system and large practice is actually coming to us saying, they recognize the issues of affordability and how complex it is. And they are actually coming to us and saying, can we work out a system together where we can rationalize payments? So my next year is going to be running around and developing with all these large hospital systems and large practices in Florida, accountable care things which get us away from this fee-for-service. So I think I really think there is some hope there. In the meantime, we have many of the same tools you have, to estimate costs, and we have to give as much transparency as possible. But the cost equation really is quite complex, and the complexity of it. We hope to just make the system just more rational so that people aren't necessarily in a position where they have to make all these decisions. Let me just tell you about one thing that's been successful for us, and that is a patient-centered medical home model. Now, a patient-centered medical home model is basically, just think of it as an enhanced primary care. It's what you would want your primary care doctor to do, would be to take responsibility for coordinating your care, making sure you got to the correct specialist if you needed it, only if you needed it, making sure that there was follow-up, helping to navigate, working as a team in the office to navigate you through your options of what your care is, explaining that care to you on an enhanced basis. We instituted a program last year trying to recruit physicians in Florida into this. And in order to make the standards, they're pretty rigorous standards, and we asked primary care docs to really transform their practice. We thought we would be successful if we got 500 physicians, maybe taking care of about 150,000 of our patients. By the end of the first year, we have 2,400 physicians taking care of 650,000 patients. Florida's primary care docs have really bought into this. Their compensation, they get compensated based on total cost of care and on meeting 29 different quality metrics. When we looked at these physicians versus other primary care physicians in Florida, they perform more than 2 standard deviations above the mean on 79% of the quality metrics that we measured. They reduced ER stays by ER visits by 12%, hospital utilization by 9%, and the net program taking care of these people, after we paid back bonuses, additional fees, and care management fees to these physicians, saved our members and our clients $120 million last year. This is very simple, it's very straightforward, and these systems are out there which are changing. Today, Sibelius announced 100 new ACOs around the country. The system is changing, and it's changing rapidly. And I can tell you, I've been doing this for a while in Florida, and 3 or 4 years ago, if you were to talk to major hospitals, large physician groups, they were saying, oh no, things aren't happening. Change isn't happening. But they really, over the past few years, there's really been this awareness within the provider community that it's no longer affordable. We have to do things differently. And we don't need to have a complex system where patients are making really complex choices at times of stress in their lives. So we hope that part of the thing, as this payment reform comes up, where 25% of our payments right now are under these systems, we hope, if my team does their job this year, that we'll have 50% of Florida Blues payments in the state of Florida are going to be under accountable care relationships. And we hope a big part of our transparency is just identifying to our members who you can go to, who's there to take care of you, and is going to take the responsibility for your quality of your care and the cost of your care.
You've heard the healthcare industry people stand up and tell you how they are changing and how they are doing things better and why they're doing a good job. And I've worked in the healthcare industry for my entire career. I now own a healthcare company that builds very advanced, leading-edge primary care medical homes that become platforms to manage clinical, financial, and administrative risk. I got news today that over the last 3 years, a clinic of mine in New Jersey, a school district, for 2,200 patients, saved $35 million, or $5,400 per employee per year. It reduced their costs by that much. The fact is that there's a tremendous amount of waste in the system, real waste that is about extracting as much money from the purchasers as possible. PricewaterhouseCoopers did a study in 2008, a highly credible study that showed that, according to their best estimate, 54.5% of all the money that we spend in healthcare in the U.S. is unnecessary and inappropriate. In today's market, that would be close to $1.5 trillion. $1.5 trillion a year just on this one issue. To put that in perspective, remember that the Congressional Supercommittee tried to come up with $1.2 trillion over 10 years, and they failed. So we are simply allowing this to happen, and we're not doing anything at all about it. The primary reason that we've gotten to this state, keep in mind that healthcare cost, the premium that you pay, has increased at almost 4 times general inflation for the last 14 years. It's gone down over the last 2 years, but it's been almost at 4 times everything else in the entire system. It is an absolutely crushing weight on the system, and it is threatening to pull the entire U.S. economy off of a cliff. Paul Krugman, the New York Times columnist, the liberal New York Times economist, who, oh, by the way, won the Nobel Prize for economics, made the comment that if tomorrow we had France's healthcare costs instead of our healthcare costs, all of our national budgetary problems would disappear. And that's true. So the real problem has to do with Michael Millinson's final comment that revolution is a transfer of power. And the question that we have to ask is, and this is, to my mind, the core question for this meeting, the question that we have to ask is, how do we, as employers, fight this in an environment where, for example, the health industry lobby in 2009, when the healthcare reform law was being developed, contributed $1.2 billion to campaign contributions, and in exchange for having influence over the result. There is only one group in America that is bigger with more influence than the healthcare industry, and that is everyone who is not in the healthcare industry. And they do not collaborate. So if you go to the chamber is not going to do anything about healthcare costs because their biggest members are the hospitals and the health plans. And we have to find a way for non-healthcare business to collaborate. So my best advice to you, the sum and substance of everything that I have done over the last 25 years in healthcare is that you need to come together, all the non-healthcare business leaders in Florida, and you need to be a counterweight to the tremendous influence that is exerted by the healthcare industry over policy. And then there are solutions in the marketplace as well. One final thing. All of the people who are in this room who I've known before I came here, they're all my friends. And they all work in healthcare, and they're all well-intentioned and smart and dedicated people. But we work in a system that is, by definition, insane, and everybody up here talks about how it's insane. Mark and I had this conversation a couple of days ago on the phone. We all agree on the problem. But we're caught up in a machine, and there's no pushback to the machine by interests that have a center of power. And so what AIF needs to provide is a genuine center of power that can be that counterweight to the industry. Healthcare organizations over the last 2 and 3 and 4 decades have built a variety of mechanisms that allow them to extract more money than they're entitled to out of the system. That sounds cold and harsh, but it's also true. Someone asked earlier about waste in healthcare. We know, for example, that cardiac stenting provides no benefit relative to drugs, which cost a fraction of the cost. There's tremendous evidence on that, and yet the rate of cardiac stenting has not gone down in unstable cardiac patients. There are 1,000 examples of this. In my company, I'm buying drugs at 35 to 40%, generic drugs at 35 to 40% of what people on health plans are paying, because most of the health plans own a stake in the pharmacy benefit management companies. They buy the drugs for what I'm buying them for. They jack up the pricing 200%. They take the margin and use it as a revenue stream, and then they tell their clients that they're managing their cost. It is a fact. It is not speculation. So what we need to do is provide a counterweight to the industry's influence, and that would be the basis of an effort toward true transparency. Thank you.
Okay, we've heard 3 interesting perspectives there, and so I'm going to try to ask some questions to maybe stimulate a little further discussion, and then at the end of the session we will open it up to questions from the audience. One thing and again, my role in this, I am a citizen legislator, I'm an employer, and I'm a consumer. And one of the things from my perspective is, first of all, as an employer, talking about you, Dr. Klepper, I don't really feel comfortable making decisions for someone else's health. And that's what I'm forced to do. The second issue is, as a consumer, I don't want somebody else telling me about what to do about my health care. I want to make those decisions. I think health care starts with the individual. So with those two premises, address how we can make the system more transparent. And let's start with Dr. Klepper, and then we'll come back down the line.
To Mr. LaBorde's and Dr. Kiss's comment, I personally think that for a very large part of healthcare, it is way too complex for most consumers to make very educated decisions. It's tremendously complex. And to Mark's earlier comment, the health plan of the future is not going to compete based on the unit pricing that it gets. It's going to compete on its ability to manage the care process effectively and do that really well. But to do that, we have to be in an environment where they do step away from making a percentage on the total for full at risk, and where they're making all kinds of money on the side on other things like drugs. So there are all kinds. We need professional managers to help guide us through this extremely complex process, and that's what the health plans are there for.
Dr. Kiss?
One of the things that I really think that's a component of it, Brian, is really the way providers have traditionally been trained. And it's really was in this system, the money was other people's money. The patients weren't paying you directly. The third-party system sort of got in the way. I went to medical school, and nobody trained me on the cost of care. No, I didn't receive a lot of training in terms of how to most efficiently deliver that care at the time I did. Later in my career, I started running training programs for internists, and I began trying to teach people how to manage care more effectively. But I mean, one of the things that we do have right now is this whole sort of generation of people who are trained, both hospitals, there was plenty of money in it. They didn't really have to look at their margin as much as they did now. The efficiency, there was no driver for efficiency. I think the system in part fed that because there was just an unlimited source of money, and half the, like for our business, half the source of money is from you for actually self-insured groups and administering that. So I think there was a source of money, and there was a lack of concern in this industry, in the healthcare provider industry. I don't think that was necessarily that they were trying to extract a maximum. I think, for instance, a doctor who sits in his office and writes for a $2,000 test that's done by somebody else that's maybe not necessary, he's not really doing that out of his own pocket, but probably out of ignorance or lack of understanding of the downstream cost. So I think there is a whole transformational aspect to it. A lot of it, Brian, is just not so much that these entities are trying to necessarily maximize profit. It's just that efficiency was never an issue, and it is now. And I think that, as training programs change and the physicians who are, using the most expensive medical instrument, the pen, as they write orders, are going to begin to take into account some of these things. When I've talked to hospital CEOs as we're putting these things together, they all know that their rates have to come down for their outpatient procedures. The realistic people more and more are coming to the realization that what they're going to have to do is to change their processes, deliver care more effectively, work with us in terms of managing a population. So, I think this transformation is happening. There is a lot of unnecessary cost, waste, as you should say, a lot of inefficiency in the system, but you can see that it's beginning to percolate through. And these arrangements, like the 100 ACOs announced today, and what we've done as a company, and what Aetna is probably as the large national has done the most. These things are really moving to drive costs in the right direction, and we really need to do it to partner with our clients who are largely large employers and work in your interest. And we as health plans will do our job best if we can assure that your employees get the best care they can at the best price to you. It's going to keep us in business because we're delivering well-priced, high-quality services.
Mark, can we hear from you?
Yeah, thank you. I do find myself coming back to some of the earlier comments, but I think they bear repeating, that we have to have the engagement of the patient. And we have to have the engagement of the patient. We've talked about in previous panels that were up here, wellness was mentioned. People have to have accountability for their own personal health as we move forward. Barring that, we have an unsustainable cost curve for healthcare in this country. And so it goes beyond just wellness. It does go into financial as well. To the same regard, as I stated, we have to enable those people, where it's appropriate, to be a consumer of healthcare. And you do that, again, by reducing the complexity in the system. Because right now, Brian said it, I think Dr. Kiss also said it, it's too complex to try to communicate. And where I think we have the opportunity, and you mentioned the meeting that happened at the national level where our chairman was part of it, I think we have the opportunity to come together and begin to remove the complexity from the system, from a payment, policy perspective again. And that's the immediate opportunity in front of us. If we don't do that, then we just leave a level of complexity that the information is confusing. And I think that's the real opportunity we have. But the engagement and again the removal of the complexity are the keys there.
Can I amplify that?
Sure.
In my clinics, if people are eligible to come to the clinics, if your company has one of our clinics, and I've got clinics at, for example, the Subaru factory in Indiana. I've got another one at the Kia factory in Georgia. I've got a bunch of clinics around the country now. If you or your family are eligible to come to my clinic, you come for free. You pay no copay, nothing. And if you use the clinic, you get all your drugs, your labs, and your x-rays for free. And that may seem counterintuitive, but the fact is that healthcare is a tremendous cost burden. And so if you make it into a very positive experience, the name of the game becomes getting people in the door, because if you get them in, then you can engage them, you can manage them, and you can advocate for them anywhere in the system. If you don't get them in, you don't have squat. So you want to knock down all of the barriers to primary care access and use that as a platform to manage everything else. It's a very important concept, but it's slightly counterintuitive. That said, if you provide a lousy patient experience, people won't come back and they'll tell all their friends. So it's a delicate dance all the time. Another thing that's very important for everyone to understand is how terrible the burden has become. RAND did a study in September of 2011 where they showed that in the last decade and now, 79% of all of the growth in household income, think about that for a minute, not household income itself, but the growth in household income, 79% is now all going into healthcare. That means that we have 21% of all national economic growth that's available for, the stuff that doesn't matter, like infrastructure replenishment and education and transportation and everything else. That's how dire it is. So we really do need to find a way to offset this problem.
Okay. Let's talk a little bit more about alternative payment systems and accountable care organizations, both from an employer perspective and a transparency perspective in terms of how this is going to help our Florida citizens. Mark, you want to start with that?
Sure, I'd be happy to. I think Dr. Kiss has covered much of it, but again, it is the transformation of the movement from what is a volume-based fee-for-service arrangement into an outcome quality-based reimbursement. I think that the thing that I would want to pause on, though, is that we throw around the term accountable care organization a lot these days. And, that's a very broad-based term, and it's a term that can mean everything from a patient-centered medical home, a bundled payment, a true vertically integrated delivery system. That, to me, is the ultimate accountable care organization. We have opportunities all along the way. We have opportunities where there is the integration to create those organizations, and we also have the opportunity to execute particular bundle payment where it's appropriate as well. The key to it all, and what has to happen to make them effective, is it has to be the information exchange within. The health information technology keeps coming up, but it is critical. The ability to pass the information about the patient on from physician to physician throughout the continuum of care for that individual, throughout their care, for there to be full knowledge as to their complete medications, everything else. That's the critical aspect of it. That's why we as a company, we purchased Medicity about 1.5 years ago, 2 years ago now. Medicity is the largest connector of the providers in the country, over 800 hospitals. And that's that recognition that led us to that decision. Again, it's not an Aetna proprietary, but it is an entity that we believe has the power to begin to make those connections. Those are what has to happen. That's when you'll get the efficiencies. That's, in my mind, among the greatest waste outside of fraud and abuse that exists currently, is the lack of coordination due to the lack of exchange of information. That has to be cornerstone.
Yeah, I would agree to say informatics is key. And as a matter of fact, one of the best advances we made in our informatics, which now reports to me because we were using all of our information really to develop these new programs, really, our thing. We really improved a lot. We stole one of their best guys, and he now works for us. And he's the smartest medical informatics person I've met. So I think one of the things that will drive this is really information. There's a lot of duplication of care that people are just doing because they couldn't get the results to the last lab test, or they didn't even know it was done. I mean, very simple things. This is not complex analytics, some of it. Sometimes it's just knowing that your patient is in the hospital. I mean, some doctors, a primary care doc, can have a patient admitted to the hospital and he won't know until they come back 4 weeks later on a whole different bag of meds because that's what the discharge doc gave and they never gave him a phone call. So a lot of the things in the information, this is really not that complex. But when you put health system, I think one of the points about these accountable care things is sometimes the stuff is really simple. I mean, some of the stuff is just really simple, like making sure that med lists line up, having the information that your patient understands their meds, that you have an active list of what your patient had, what he actually filled at the pharmacy, and we can now give those kinds of information. So I think that's one of the things that will help with the inefficiencies in this is the information flow. And, what's going to be the benefit of these things? You know what? It's still something of an experiment. This is a new. We're moving into these things. What have been the outcomes and the real dollar outcomes? You heard from the first speaker today talking about the alternative quality contract in Massachusetts, kind of looking as a success. It really didn't save any money because the payment formula wasn't so great. People got good care, but it really didn't save any money. We look at a lot of patient-centered medical home demonstrations around the country, and ours seems to be having a very positive result. A lot of them are having equivocal results. So these models are all promising. We are getting the discussion and the focus on efficiency and on improving quality, but none of these, I think, have been the established magic bullet that we all need to jump on the train and everything gets better. So I think what we're doing is just trying, and I think just as a system with working with employers and working with providers, is develop this kind of collaborative environment where instead of this thing where providers never trusted insurance companies, our clients didn't necessarily think, our business clients didn't think we're necessarily acting in their interest, to just realize that this whole shared issue of affordability affects us all, and we're all working on the same things, and we're learning together, but this focus on affordability and the focus on quality is really new to the system and really to penetrate for people where provider systems, again, a few years ago were saying, I don't want my quality published, I don't think you can do it, I don't care about cost. The conversation has changed, and that's, I think, the first big step that we have. And what are people going to see from this? I don't think we can, guarantee things. We are putting in trend guarantees for people going to ACOs for employers, and we are putting those things into our contracts, but we're taking the risk that these things are actually going to save costs. So a lot of the things, even the employer-based clinics that Brian talked about, a lot of them have shown and reported some improvement. There was an experience at Caterpillar first couple of years. They did something like that, looked good, and then 2 years later they'd abandoned it because they did a reanalysis and said it didn't work. So a lot of these things, it isn't just the model, but it's how you do it and some of the nuances. And this is all new, and I think we're all learning, and it's an evolving process. And I think the one thing that employers can do is to really realize that environment of mistrust, and we all need to collaborate in order to assure quality and efficiency in healthcare.
It's worthwhile talking about for just a minute the problem of care coordination. And the chief impediment to care coordination has been the fact that the electronic medical record vendors in the country have refused to agree to a given standard. So at this point, people who own different electronic medical records, and sometimes even if they own the same one, they can't exchange information at all. And by that act, and the electronic medical record vendors have done this because they want to protect their market share. If I can easily move my data to somebody else's system, then I can also they can move their business to somebody else's system. So they want to be able to hold the purchaser hostage once they've bought the system. Well, if you think about it, what that has done is effectively held the entire U.S. healthcare system hostage because we can't track what's going on between providers who are in different systems, and so we can't coordinate the care process very effectively. So what that has done is it has added hundreds of billions of dollars a year to our national cost, and it has killed, as Newt Gingrich said, thousands of lives a year because we simply have allowed it, and they've got good lobbying representation. That's exactly the kind of problem that we're talking about.